Hello and welcome. My name is Dr. Jack West, and I'm a medical oncologist and the founder and CEO of GRACE, the global resource for advancing cancer education. This is part of a series of podcasts covering challenging clinical cases in lung cancer that don't have a clear, correct answer for the best treatment based on the evidence, and they therefore require our best judgment as experts consider the options and the merits of one treatment over another. The same series of cases was discussed with multiple experts in the field of lung cancer from several different institutions to provide a better sense of where there is consensus and where there is still a wide range of treatment styles that might all be considered appropriate. Each podcast starts with a brief thumbnail of a case presentation and then discussion from a live program done with Dr. Robert Doble, Assistant Professor of Medical Oncology at the University of Colorado Medical Center in Denver, Colorado, and Dr. Jyoti Patel, Associate Professor of Medical Oncology at the Feinberg School of Medicine at Northwestern University in Chicago, Illinois. The discussions will then continue with commentary by several other clinical experts, including Dr. Suresh Ramalingam from the Winship Cancer Center, Emory University in Atlanta, Georgia, Dr. Jonathan Goldman from Premier Oncology in Santa Monica, California, Dr. Julie Bramer from Sidney Kimmel Cancer Center at Johns Hopkins University in Baltimore, Maryland, Dr. Heather Wakely from Stanford University Cancer Center in Palo Alto, California, and Dr. Karen Reckamp from the City of Hope Cancer Center in Duarte, California.
A 71-year-old woman with a good performance status is referred to you about 4 weeks out from a right upper lobectomy for what the pathology showed was a 3.5 centimeter poorly differentiated adenocarcinoma with some lymphovascular invasion.
She's worried about that and is certainly willing to do chemotherapy, but she's also not absolutely steadfast about that. This is a cancer that's not as large as we would definitely recommend for chemotherapy. So, Jyoti, if I could start with you, what would you be thinking about a tumor that is smaller than what we might consider our typical cutoff, but is higher grade and has some worrisome features in terms of getting adjuvant chemotherapy?
The first thing, though, I would address is how confident I felt about the surgery. A tumor this size at my institution, we would probably plan to do a preoperative mediastinoscopy, and then in the pathology, I would look carefully to make sure that I felt there had been enough sampling. If it was certainly the case that the patient had been what I believe was truly pathologically staged, then the conundrum is tough. Certainly, she's at high risk of recurrence by oncologic standards, but again, she's in a good scenario by lung cancer. 1 in 5 of these people will have recurrent disease. And so we have looked to give patients adjuvant chemotherapy for a couple of decades. The available evidence suggests that chemotherapy for her stage of disease, meaning no lymph nodes positive, would suggest that chemotherapy would be detrimental and may actually reduce her survival in a population. However, she has features that are high risk, and she does have a difficult tumor that could be susceptible. I don't think in 2011, though, we can pick out those patients, and the chemotherapy comes with toxicity. So I would likely suggest to just follow her expectantly and to hold off on adjuvant chemotherapy.
Bob, how would you approach this kind of case, a little smaller, node negative, but some higher risk features?
First of all, I definitely agree with making sure that an adequate staging was done with mediastinoscopy. I think that's an excellent point. I also agree that currently there is no good data to suggest a benefit in this patient population. It is our standard that patients with 1B disease, no matter the size or features, do get referred to a medical oncologist for a discussion of the potential risks and benefits of adjuvant chemotherapy in this group. Even in a case where the tumor is greater than 4 centimeters and there was some post hoc analysis suggesting that there may be a benefit in this group, in the CALGB 9633 trial, it's still a very difficult conversation because if you look at the data from stage 2A non-small cell lung cancer, the absolute improvement is only about 5%. Out of 100 patients that you treat with chemotherapy, only 5 are going to benefit. It's an incredibly difficult conversation under the best of circumstances. I've considered chemotherapy in this group before, but I typically won't recommend. I have a very long and careful discussion with the patient about the potential risks, and I agree with Jyoti's point that there actually can be harm, and there was a suggestion of decreased survival in patients who had tumors less than 4 centimeters in that group.
Dr. Suresh Ramalingam from the Winship Cancer Center, Emory University in Atlanta, Georgia.
For node-negative cancers that are less than 4 centimeters, the current data are not supportive of use of chemotherapy. In the CALGB trial, there was some disease-free survival advantage, but there was no clear survival benefit that was statistically significant. And that has changed our practice. That and the results from the NCI Canada trial, in which the subset analysis also showed that the 4 centimeter to be a determinant of robust benefit versus lack of benefit. So when I have patients with less than 4 centimeters, my overall recommendation for them is a wait-and-watch approach or a regular routine follow-up approach. I struggle with this issue when there are these features in the tumor that would suggest maybe this person is at higher risk. But I think the stage does capture their overall prognosis with variations from one to the other. So my thought is to observe them and not offer chemotherapy.
Do you think that in some of these patients with smaller tumors, we may be causing more harm than benefit from giving chemotherapy?
In stage 1A, at least the meta-analysis showed that the hazard ratio was 1.4 with adjuvant chemotherapy, where it clearly is indicative of harm. In stage 1B patients in that meta-analysis, the hazard ratio was 0.92, which is as close to 1 as you can possibly get. And that tells us that at that level, there may be some patients we may be helping and a few others within stage 1B that we are not helping and potentially be harming with chemotherapy. Those are all considerations when we make these decisions. And that's why I tend to use this 4 centimeters as the cutoff based on the best available evidence as of now.
Dr. Jonathan Goldman from Premier Oncology in Santa Monica, California.
I think adjuvant chemotherapy is a very special circumstance that you face as a medical oncologist because you hope to have the opportunity to cure a patient. You have to weigh against that the toxicity and also the uncertainty. You never know which patient you benefited and which you didn't. As you said, tumors greater than 4 centimeters, most medical oncologists are advising to undergo chemotherapy. And certainly when there's lymph node involvement, those are more clear cases. A slightly smaller tumor, then really you're doing your best to weigh risks and benefits without clear evidence behind you. And it comes down a lot to the patient, and in this case, this woman, it sounds like otherwise she's healthy, and the values that she has. In this circumstance, many people lean towards wanting to do whatever is possible. And you have to advise a patient to not go too far in that direction. Since you don't know how much you're benefiting the patient, you have to temper all of the decisions and not try to rashly make a decision just out of fear. At the same time, someone in this circumstance with a 3.5 centimeter tumor that's quite close to 4 centimeters, if someone is wanting to undergo more therapy, I think it's reasonable. I have other patients with a 1.5 centimeter tumor, and there I feel quite strongly to advise a patient not to. Some of the data even shows a detriment for those smaller tumor patients.
Dr. Julie Bramer from the Sidney Kimmel Cancer Center at Johns Hopkins University in Baltimore, Maryland.
I think size isn't all of the answer, unfortunately. Certainly discussing adjuvant chemotherapy with this woman. She's not an elderly woman, but certainly on the cusp. Ideally, cisplatin-based chemotherapy would be what you'd want to use in this case, but not all patients can tolerate cisplatin, so certainly that has to be taken into consideration. The poorly differentiated adenocarcinoma makes you a little bit uncomfortable suggesting not to do chemotherapy just in the fact that this may be more of an aggressive tumor. So some of the history behind that would be good to know, like how quickly did this come up, if there was any sort of history of a nodule there previously. And also sometimes we'll look at actually EGFR mutation as well as KRAS mutation And in someone who would be KRAS mutation positive adenocarcinoma, that may be a little bit more aggressive type of tumor, I may want to try some chemotherapy in hopes to prevent the tumor from coming back. But even as a stage 1 tumor, she actually has a high chance of this not coming back. But unfortunately, not all patients are that lucky and do have the tumor come back in about 30% of the patients.
Do you ever use molecular factors like ERCC1, which in the IALT bio retrospective analysis suggested it might be of some use in discriminating who's more or less likely to benefit, or does its lack of prospective validation keep you from using it?
I think the lack of prospective validation does keep me from using it. However, some of my patients do come with that data already, and I try to incorporate it with the caveats that we talk about. If the person looks like that they would benefit from platinum, their tumor would benefit from platinum, then potentially we'd push a little bit harder than someone who we know whose tumor probably wouldn't, but we don't know that in a prospective fashion. I don't routinely order it on my patients.
I believe that the data from the JBR10 adjuvant trial suggested that the people who have a RAS mutation don't benefit from adjuvant chemotherapy, even if they may have a worse outcome overall. So it's tough when the data might suggest that, if anything, you might provide no more benefit for those particular people. Dr. Heather Wakely from Stanford University Cancer Center in Palo Alto, California.
Part of it's going to depend, obviously, on how fit she is. If she is very fit, then that makes it a harder question. If she's not so fit, I think that makes it easier because there is certainly potential harm from the chemo. Part of it is her anxiety level about getting treatment and feeling like she's done everything possible. And then I would talk about the data with her and explain that for a tumor that small, we don't really have any firm data of benefit. That being said, I don't think there's anything magic about 4 centimeters. I think there's a continuum of benefit, and probably the smallest tumors, there isn't any benefit, and the bigger tumors, there definitely is, obviously in the absence of lymph nodes. And in that, where is that magic number? I don't think we know. 4 centimeters is what's been looked at in a couple trials, and that's certainly what we use in clinical trials that are ongoing right now, like 1505. So she wouldn't qualify for that. But 3 centimeters, she's going to be anxious and feeling like she's not done everything. She's otherwise healthy. I don't think that giving her 4 cycles of a cisplatin-based regimen would be wrong, and I would certainly give that to her as a possibility. The lymphovascular invasion is a interesting component of that. We don't really know what to make of it. There was an abstract presented at the Chicago Lung Meeting in December where they looked at vascular invasion and showed that that was as significant in their analysis as having some nodal involvement or having a bigger tumor. And so I don't think that's validated enough yet to really use it, but it certainly adds to the discussion with her. So I wouldn't strongly endorse it, but if she came across after that discussion and said, I really would want to do it, I wouldn't feel that it was a wrong thing to do.
Dr. Karen Reckamp from the City of Hope Cancer Center in Duarte, California.
So I think the first thing I think about is the size, and based on the subgroup analysis, looking at chemotherapy for stage 1B, I use the 4 centimeter rule. Other high-risk features, I know the NCCN guidelines talks about other high-risk features, but those have not been clearly identified in any clinical trial. So in a patient like this, I take the performance status and other comorbidities into account and would have detailed discussions about the risks and benefits, because even with chemotherapy, they're in the range of 20% grade 3, grade 4 toxicities associated with it. So I think I would recommend in this case for close monitoring and probably not recommend chemotherapy, but would give a balanced discussion of the risks and benefits of chemotherapy.
We hope that the program was helpful, and we'd again like to thank the folks from Longevity Foundation for their partnership on this program. Thank you.